Good morning to you all, and thank you, Chitra. I'm going to talk on about when ICL can be advised or can be done. So this controversy is always going to be there. So when can we do LASIK, surface, or a retinal pathology? So if a patient has lattices in the retina, you can of course laser them and then go ahead and do a application. If the patient does not want that, then you can do a surface if you have a fear that the pressure on the eye is going to increase. So when can you think of flaps or ICL in today's option? So when to create a flap, when to create surface, when to do LASIK, when to do ICL is what I'm going to show. So in a pre-op analysis, we all know that there is a refractive error and the relation is to pachymetry. So we have to know the photopic pupil, and we do this, and accordingly we calculate the optical zone is analyzed from the wavefront analyzer. And from the op scan, we can get or a pentacam or a G6, whatever method that you have to rule out keratoconus, and we have to get the anterior chamber depth from the op scan. So when LASIK is not possible, for example, a refractive error of 10 with a 2, astigmatism at 180 and a Phakic of 480, obviously we know that LASIK is not possible, and the pupil is 6.3. So then, and if the anterior chamber depth is 2.82, we know that the cutoff is 2.80, then this patient can be advised on toric ICL. If other possibilities are 10 with 2, 180 and a Phakic of 510 and a pupil of 630. Now many people do not do surface treatment for more than -8, even I don't do that. Of course, then this patient has a good anterior chamber depth, can go ahead and do ICL, which is a toric ICL. But of course, if you think of doing LASIK, we want a residual bed. Now I keep a residual bed of 300. Now just to show you a surface treatment, what I have is something called as Epi-Lasik. Here the epithelium is also removed by the laser itself. So there's no scraping, there's no alcohol, there is nothing. This behaves much better. Now we have something new called as the smart pulse technology. The ablation is much more closer, the healing is much more faster. Normally in Epi-Lasik, it takes about 3 to 4 days to properly get epithelized and the patient gets better vision. But in this case, it's even faster. In about 1.5 to 2 days, the epithelium has healed. Of course, the surface is a little raw, but as you can see, there was nothing really applied here. You just make the surface dry, and the whole treatment is done by the laser itself. So the ablation of the epithelium, you get a very well punched out margin, and this works quite well. Now let's look at the relationship between pachymetry, and we know that there is a percentile that has to be calculated. So if the refractive error is 5 with 2 at 90 and a Phakic of 470 and a pupil of 660 and the pentacam is normal and no family history of keratoconus, then you can think of whatever other options that are there. But the most important is this, the flap thickness plus ablation depth divided by central corneal thickness. So the percentile calculation is important, but recently there was a paper presented where they crossed the percentile, and 20% of the patients were beyond the percentile, and yet nobody developed keratoconus. So this formula that we have been following for so long may also be questioned in the near future. But this is what we are following now at this level. So coming to ICL, what are the complications? As you all know that there is cataract and glaucoma, but this all has to do with sizing. So sizing is 99%. If you have the right sizing, your job is done well and quite easy. So I'll just show you some example. The sizing can be done by op scan, UBM, pentacam, IOL master or caliper, depending on what you have. This is not going ahead. Okay. And the methods can be validated in different ways, but the most important is white to white. And here, if you have an op scan, even the ICL people follow that. That's the star ICL. And of course, you have the IOL master, but be careful if there is a pterygium or a pigmented area on the cornea. There can be discrepancies in different devices. Now, UBM, you can see the sulcus is measured, and the op scan also gives you a white to white. So there are two different methods of checking the same thing out. And here you see a shallow vault. So you can see that the ICL is very, very close to the anterior surface of the lens. Now this, if it is less than 0.125, it may lead to an anterior subcapsular opacification. So you may get dot cataracts. They normally don't progress. I've seen this in the past, and they remain at the place where there is contact. A large vault, you can see the old PI, because the old ICLs did not have a central hole. Nowadays, you know that it is there. But if it is a large, more than 1 millimeter, it may push the iris up. It may cause peripheral anterior synechiae, and this may lead to glaucoma. So this is one thing that is possible. Of course, the ICL, you can see the distance between the posterior surface and the anterior surface. So this is an ideal vault. The ideal vault is 0.25 to 0.75 away from the anterior lens capsule. So this is the right vault that we want in every case as far as the ICL goes. So you can see the distance between the anterior lens capsule as well as the ICL. So this is what we want to target for each and every patient, and its summary is again that sizing is the most important thing, either an electronic caliper, even getting it from the UBM and as well as getting it from the op scan. Complications are, you know, that halos, glare, pupil ovalization, iris retraction and atrophy. Rare complications are corneal decompensation, a Hewitt-Zavalia syndrome, malignant glaucoma, end of an ifema. ICL, the problem is if first 3 days we have to give the patient oral Diamox because the patient's pressure goes up, and that's mainly because of the methyl cellulose that may have remained. You all know that when we use viscoelastic, never ever use a heavy viscoelastic. I only like to use methyl, so do not use a Helon or a Viscoat or a Helon GV or anything like that. You have to put below, and when you finish putting the ICL, you have to make sure that with the Simcoe you go beneath the ICL and wash off all the methyl. The new ICLs have a central hole, so you really don't need to do an iridectomy, what was necessary in the past. That is not really necessary. Some of them do develop uveitis and endothelial damage, surgical trauma. All this is routine what can happen because of surgical problems. So if the diameter of the lens that is implanted horizontally, always remember that ICLs are implanted horizontally. They are never placed vertically because the calculation of your caliper is always horizontal. Another thing, if you want to put a toric ICL, the company will do the calculation and tell you to move the ICL 10 o'clock position anti-clockwise or 10 o'clock position clockwise. So that's all you have to do, and when you put the paper and check that you have to move it anti-clockwise or clockwise, you can use modern technology like the Virion or the Callisto, and that itself can help you to rotate the ICL on the table if necessary. Otherwise, just do a marking and you can rotate the ICL as necessary. So that is quite possible in today's world. Contraindication for ICL, you all know that if the anterior chamber is very, very shallow, it's not possible. Other contraindications like cataract, glaucoma, etc. is quite possible. Spontaneous rotation of ICL is known. Newer ICLs, as I mentioned, does have a central flow. Just to show you one video, this is an ICL, this is a toric ICL. Now this patient's developed a cataract. I'll take a minute more. And when it comes to removal of the ICL, I'm going to show you this. Bring the ICL in the anterior chamber, rotate the ICL in the direction of your incision. And calculation as far as the IOL goes is very, very easy. With the ICL in position really doesn't matter. Do your optical biometry, do your calculation, remove the ICL. You have your wound ready, just go ahead and do your phacoemulsification and place the lens. So here you will see that I made the ICL horizontal. Go ahead and hold with the forceps. Now I'll just show you one step here that once I've held it with the forceps, I try to bring it out through a 3.2 and it slips once and it goes back, but it really doesn't matter. As you see that, it's slipped and it's gone back. Don't worry, go back in, hold it and pull the whole ICL out. So it's as easy as that. This is quite easy. I'll show you one more method of removal of the ICL. Again, a small incision, a micro grasping forceps. Go ahead. Now the Indian ICLs are much thicker. If you know that the one made by IOCare is almost 250 microns, I'll take 30 seconds more. So it's not very easy to remove them. I've cut this ICL in the anterior chamber and then just bring one half out and you've gone till the center. So you don't need to cut it through and through till the other end. Just go ahead, bring it through the center and then rotate it out. As you can see this, I'm rotating it out and bring the whole ICL out. Then go ahead and do your phacoemulsification, do your Rexis, do your phaco. There was a little bit of prolapse and that's done. Put the lens implant and that is done. So this is quite possible. In summary, for LASIK or laser, when it's not possible, borderline cases prefer to do surface. If that is not possible, go ahead and do ICL. That is how I advise my patients. And if nothing is possible, one option is of course there for a multifocal clear lens extraction. So LASIK or laser or ICL or clear lens extraction, surface treatment if not possible, good anterior chamber depth ICL is advised. Thank you for your attention.